today is talk about the management of medical care for people who have very high medical expenses. And I just want to say that I'm interested in this increasingly because, as many of you know, I used to focus on, or I have been focusing on, the risks that insurers face in these markets and why it's so difficult for individuals and small employers to get health insurance in the private market. And in particular, I've focused on this risk of adverse selection. That is that the insurance company is very worried, as would I be if I ran an insurance company, about having a disproportionate number of people who have very high costs. But increasingly, in this last year or so, I think it's become obvious to all of us that we can't keep expanding health insurance options for people who are either poor or near poor, where we might be providing subsidies along with trying to deal with this risk of adverse selection in those markets. We can't do that unless we can get more revenues in the system, i.e. tax revenues. And this is getting hurt by the fact that medical expenses have been going up so rapidly. They've doubled in just the last 8 years. And in particular, if you're worried about very high-cost people, one of the things I want to go through is that not all people who have high expenditures are risky in terms of, you can't assume automatically that once you put a little flag on their claims record that they're going to be high cost the rest of their lives. And that means that we need to do more, it seems to me, on thinking hard about how do we manage these healthcare costs of people when they go above some line that's sort of like a tripwire that is indicative that they are probably going to have very high medical care costs that year. The question is why? What's going on here? I think that if we can't do more in being efficient and providing high quality care to people who are very sick, who end up being these high cost people, then it's hard to go back to taxpayers and say, look, we need more revenue to help make this possible for everybody in the state or in the country. So what I want to do is go through some of these tensions that I've just sort of laid out and talk about the fact that high-cost people are not all high-risk people. And then talk about, as Courtney said, these different risk management strategies that states have been working with. And then talk more about what can states do, and can they do this by themselves, or do we need to have this as a federal initiative to really try to control these risks of these high-cost people. And the bottom line on this is I don't think that states can do it alone, even a state like New York. But I want to go through all of that. So I want to also just say that some of what I'm going to say is probably perfectly obvious. It seems to me that a lot of it is obvious, and especially to those of you in this room. But I think it's useful to think about healthcare costs as, you know, it's like a Pac-Man in our old way of thinking about this. It's now at 16.5% of our GDP, and there are a lot of other competing interests for that money that we have or produce in our economy. And what I'm really getting worried about is these high-cost medical expenses crowding out initiatives that have to do with infrastructure, for example, and thinking about how do we keep this country productive over the next 50 to 100 years. How do we put more money back into education issues so that are we setting up a battle between older people and younger people? I don't think we should be doing that, but we ought to be thoughtful about what monies are we spending on medical care that otherwise would go to some of these other areas that states have a strong interest in, and the U.S. certainly has a strong interest in. So that's where I'm going with this. Let me ask you a question, since I feel like this is echoing. Do you need this?
It's a question for the back of the room.
Because I can project fairly well. Can you hear me?
Yeah. Yes.
All right, so I'm going to take this off. Sorry. Okay. That's better. Can you still hear me?
Yes.
All right, so I'm going to go through some stuff fairly quickly that I know all of you really do know. But just to, it sometimes I think helps to be reminded of this. We have, at the moment, at least 50 million people in the United States without health insurance. And any of us in this room can do as good a guess as I can about really what that number is. I think this is Even when we get the estimate in August from the current population survey of what it was in March 2009, that probably won't really reflect what's going on by the summertime. We have estimates that there's probably a similar number of people who have poor health insurance, what we might call underinsured. So we're talking about basically somewhere between a sixth and 1/3 of the U.S. population have problems paying for their health care. The efforts that we've been focusing on so far in the United States to expand health insurance coverage have focused particularly on expanding Medicaid, the CHIP, the State Children's Health Insurance Programs, and in providing subsidies to people whose incomes are above the income ceiling for being eligible for Medicaid. So calling them near poor is, depends on which state you're talking about where that is, but you know what I'm talking about, that we're talking about people who are not eligible for Medicaid but clearly cannot buy health insurance on their own without a subsidy. The problem is that the costs of care are rising faster than general prices are rising, than incomes have been increasing. And as I said a minute ago, the cost of health care just doubled in the last 7-8 years. So we are facing a real problem here. The tensions really come about because of this growth in healthcare spending. So again, just to remind you, we're talking about 2007, which is the last year we have this data for, that we spent $2.2 trillion. That's more than $7,400 per person in the United States. It's more than 16% of our GDP. And 3/4 of that $2.2 trillion, the best estimates are that 3/4 of that was spent on people with chronic illnesses or conditions. So you can, from the get-go, start to see that a lot of the healthcare spending is on people who have predisposing reasons for having higher medical needs, and therefore you could expect they might have more healthcare given to them. Medicaid accounts for 7% of the federal budget right now. On average, it's a little more than 21% of state budgets. I assume in New York it's higher than that. New York spent more than $38 billion on Medicaid last year, which, when you put that in the context of you're looking now for a $3 billion cut in the state budget, I mean, this is a lot of money to be spending on Medicaid. Medicare accounts for about 13% of our federal budget, and I think what we're really running into is resistance from people, especially in a recession, for how are we going to pay for expanding health insurance coverage when we're in this kind of a situation. You all know that we already pay for uninsured people in lots of fairly hidden ways to most people in the United States. These subsidies that we're now looking for, monies for subsidies to help people buy private health insurance, are just going to add to people's anxiety about how much do I have to keep paying in taxes to help provide help to other people. I do believe that a lot of people know neighbors or their grown children that don't have health insurance, and so they're very aware of the fragility of health insurance coverage. But when they're also very worried about whether they're going to lose their job, you're starting to get into this clashing on this. I want to say that one of the things that, and I'll come back to this when we talk about Massachusetts, but this hidden money that we use to pay for people without health insurance, in Massachusetts we have this uncompensated care free pool money, which has been essentially just taken from one part of the ledger and moved over to being used to pay for the subsidies for people to buy health insurance in the Commonwealth care. And that's something that I think when people talk about what are the problems going on in Massachusetts, it's something to be reminded of, that so far this is working in Massachusetts because we had this pool of money that I think for a lot of people they sort of knew about it, but it was hidden in many ways. But it's being used now for this. No other state really has this kind of kitty of money to call upon. Okay. I want to also make the point that it's not just taxpayers and those of us who are involved in the public sector who are concerned about these rising healthcare costs and what are we going to do about health insurance. This is clearly a problem for self-insured firms, for any employer, whether it's a government at the state level, county level. And I think that the issues are fairly well known. We have these unfunded liabilities for healthcare costs of retirees. I totally expect that the percentage of people who will get retiree health insurance benefits is going to go down. Premiums for the current employees now account for about 7% of compensation. And just for comparison, I want to make the point that in 1960, what employers paid for health insurance benefits was only about 1% of total compensation. So what started off looking like, well, this is a small cost, we can do this, is now one of those items that employers are very concerned about, the fact that they don't have control over how rapidly that part of the compensation is going up. And I think that the current recession is really providing, whether you call it an excuse, whether you call it an opportunity, it's a point of leverage for trying to reset what employers are providing in the way of health insurance. And then the last point I want to make about this is that it's not just small firms that are concerned about people with high costs and their ability, the small firms' ability to get health insurance in private markets. All firms, large and small, are very concerned about what they're paying out for people who have extraordinarily high medical care expenses. This comes up in discussions. I sit on the benefits committee for Harvard University, and while we don't know who those people are, it is clearly an object of what can we do to try and reduce those costs. So this is an issue, it seems to me, that's both out there for politicians worrying about taxpayers and their resistance to paying more in terms of revenues to help expand health insurance coverage, but it's also an issue, a big issue for the private sector. So let me turn a little bit to talking about risk and insurance. Again, you all know this, but I think sometimes it helps just to be reminded that there are two different types of risks in insurance, health insurance markets. The first risk, which is that as an insurance company, you're projecting out, or if you're a self-funded firm, you're projecting out what you think the medical expenses will be in the coming year for your employees and their dependents, or if you're an insurance company for all the people that you're covering. But of course you know that in any given year, your projection could be off. I think the last 2 months have vividly reminded us of that the cost of having a new flu, that we don't have a sense of how rapidly this is going to spread, how much it's going to cost, who is going to be mostly affected by it. But that kind of risk is there year after year. It's just that it came up abruptly in the spring for all of us. Insurance companies always worry about a new vaccine that might be coming on the market. They have these committees that go out and they look at what's coming online, when is it likely to get approved by the American Pediatric Association, for example, or the CDC. But if they guess wrong about whether the new vaccine is approved in, say, April as opposed to September, and then the company that's producing that vaccine, which has been saying all along, oh, maybe it's going to cost $200 for the required number of doses, whatever that is, and then they come back with a price closer to $400, that can blow your projections completely. So that's clearly a risk here. It's part of why insurance companies are very nervous about aggregate expenditures of all the people that they're insuring. It's also why employers get very worried about, again, aggregate expenditures. The second risk is the one that all of us have been talking about for quite a while, and this is this adverse selection risk where you have a disproportionate share or number of people who have extremely high costs among all the people that you're covering by a set of policies or a particular policy. And this risk is much higher in a world like we have, where we have voluntary health insurance purchasing. If we required everybody to buy health insurance, the risk of adverse selection would come down greatly, because it's clearly people who think of themselves as being healthy, young, why do I need health care, I'm not going to get sick this year, who don't want to buy health insurance unless it's required. I'm going to come back to this point again, but I just wanted to sort of distinguish these kinds of risks that are out there for insurance companies. So the next thing I want to talk about is, what do we mean by very high costs? I've just thrown this out there before about talking about the risk of having some people with disproportionate number of people with very high costs. So what am I talking about here? The first thing I want you to notice, if I can do this correctly, is that this bottom 50% of the population is responsible for only 3% of all healthcare spending in a year. So this is, let me explain a little bit more about this graph. So what I've got here on the vertical axis is the cumulative percentage of expenditures, which obviously you're going to stop at 100, but the only way I can get this graph to work was to go up to 120. And then on the horizontal axis, what I'm doing is I'm going out and just adding people to this cumulative number of people in the population, and I'm doing this in a stacking way based on what their medical expenditures were, say, in a particular year, whether it's last year or whatever year you want. So those people who have zero expenditures are obviously going to be down in this part. We're just going to pile them up. They have zero. But as soon as you start to have some medical expenditures, maybe a couple $100 because you went and had a checkup for something that you were worried about, maybe you spent almost $1,000 because you had a physical, then you are going to be in this section of my graph. So you're only out in this part if you have had very high expenditures. So this point that half of the population is responsible only for 3% of all healthcare dollars in any given year is something that I think most of us know. If you talk about the top 30%, so here it's 70, okay? Everybody here is in the top 30%. They, sorry, I don't want to do that. I want to do the top 20%. So we're here, and so if you went up from 80, you'd be at 20% of all expenditures. If you get up to the top 10%, so that would mean you'd be in the 90th percentile, you would see then that if you were in this section, you are responsible for 70% of all healthcare expenditures. So this is something that I think a lot of us hang on to, that people in the top 10% of the the expenditure distribution are responsible for 70% of all healthcare. Okay? Then if you get up here, this 99th percentile, if I go up here, I can't do this right. So then right here, okay, so if I went over, I would be at 70. So people who are in this top 1% are responsible for 30% of all healthcare expenditures. Those are the people that I'm very worried about because they have extraordinarily high costs that land them in this being in the top 1% of the population, and they are responsible for this 30% of all expenditures. Those are the people that insurance companies dread coming into their insurance pool unless they've got lots and lots of these people down to the bottom 50% to balance them off. Okay? So it's in that sense that I just want to make this point that we can talk about people with very high expenditures and then most people have very low expenditures. And I'm going to come back to this again in a second. So let me do this, because I think it's important to realize that in spite of my making a big deal about these people that are in the top 10% or the top 1%, it is not the case that these people who have very high expenditures in a particular year are going to be up in that same very high expenditure portion of that graph in the following year. So this is from Alan Monheit, who's at Rutgers, and has pointed out that less than a third of the people who are in the top 5% of that expenditure distribution are in the top 5% the following year. Only 45% of the people in the top 5% are even in the top 10% in the following year. So less than half of all those people who are in the top 5% find themselves in the top 10% in the next year. So there is a lot of regression to the mean here. That is that people can spike and have very high expenditures for a year, possibly 2 years, but then their expenditures start to go down, and I'm taking out people who died. So these people, expenditures go down. And in spite of the fact that we say that this point that 70% of people in the top 50% are in the top 50% in the following year, it is important to remember, going back here, that to be in the top 50%, you're still talking about, you've got fairly low expenditures in this area. So this doesn't mean so much to say that 70% of people are in the top 50% again. But I think a lot of us seem to believe it does. Are you with me on that one? Okay. I think it would probably also be useful if I just go back to this for 1 second and make some comments about thresholds. That is, what dollars worth of expenditures do you have to get over to get into, say, the top 10%, the top 2%, or the top 1%. So to be in the top 10% of this distribution, which would get you here, being in the 90th percentile, you would have to, in 2009, so this is doing an inflation adjustment to the expenditures that Alan Monheit calculated using the medical expenditure panel survey and making a sleight of hand on what kinds of changes we've had in the way we provide medical care. But basically, to be in that top 10%, your health expenditures this past year, so 2008, 2009, would be about $20,000 or more. Okay? To be in the top 2%, they'd have to be above $40,000. And to be in the top 1%, they'd have to be above $60,000. So, you can think about people you've known who've had surgery or have dealt with say, cancer and have gone through a successful chemotherapy treatment. You can pretty much peg where you think they would be, whether they would be in that top 10%, but not the top 2%, or the top 2%, but not the top 1%. We can all play those games once you know what the thresholds are. So keep those dollar figures in mind, because they, on one level, are relatively low for being in these high sets of expenditures, to be way up in there. On the other hand, to go across a threshold of $20,000, anybody that's had some significant surgery is clearly going to go above $20,000. Whether they go above $40,000 is less clear. Yes?
Are these 03 numbers, dollar numbers?
No. This is using Alan's expenditure data from the maps and just calculating what percentile you're in. And then I'm giving you the dollar figures based on what he did and what I did for one state, where I could look at all people who have small group health insurance and individual insurance, and it was amazing. It mapped right into what Alan had done. And then I've adjusted for inflation. Okay, so the main point I want you to take away from this is that we can talk about people as being high risk for high cost, but it's not the case that all people who have high costs in a particular year are going to continue to be high cost people, and that there's a lot of variation and differences in what those costs are, depending on whether you're just in the top 20%, where you can have a fairly low threshold to be in the top 20%, versus once you're up in the top 2% or 1%, those are fairly sick people that we're talking about. So let me talk a little bit about this. Why do people get in these very top percentiles? First thing I want to say is that people who are in that top 1%, so to have annual expenditures, say in last year, above $60,000, we're talking about very sick people. Something has happened to them, and by and large, it's a random occurrence. So things like having a premature baby, so that you may end up with a preemie who's in the hospital for $250,000. There may be high expenditures for that child a year later as well, but by and large, the regression to the mean and the expenditures come down fairly steeply from having a premature baby. Another example might be somebody who has a stroke and survives it. During the first year, there may be quite a lot of physical therapy, a lot of intense hospitalization costs when the person goes into the hospital with a stroke. But if the person survives this fairly well, again, those costs can come down pretty rapidly over a 1 or 2 year period. A third example might be one of the young invincibles having a car accident and surviving that. And again, maybe a lot of physical therapy, because you could talk about broken arms, broken legs, whatever, hips, and so you can end up having quite a high expenditure, well above $60,000 in 1 year, but not necessarily after a year's worth of intense physical therapy and recovery. People in the top 10% for 2 consecutive years, so remember the threshold for being in the top 10% last year would have been around $20,000. So when you see people who year over year are in that top 10%, they are much more likely to be older people, they're likely to be female, and they're likely to have a chronic condition. The female part of this often reflects that the person is living alone, could well be a widow or a divorcee. There is not a spouse helping to take care of this person. So that immediately starts jumping up the expenditures. And the conditions that have been noted particularly for getting people into the top 10% of our expenditure distribution are these chronic conditions like various cancers, mental health conditions, arthritis, diabetes, pneumonia, connective tissue disorders, some stomach problems, gastroenterological problems, hypertension. And I want to make the point that these conditions right now reflect a lot about how we treat people with these conditions. If we were to come up with a vaccine for various viruses that cause cancers, for example, my guess is that cancer would drop out of this list. And so it's important to think about this in terms of how are we treating people who come in with specific presenting symptoms or conditions, but not to do this as a condition list, because I'm willing to bet you that in a decade, some of the items on this condition list we wouldn't want on this list anymore, and there are others we haven't yet encountered that should be on this list. For an insurance company, the concern is really people who are in that top 1%, particularly of the expenditure distribution. That is that the threshold for being there is that their healthcare expenses go above $60,000. But for our purposes, in terms of focusing on adverse selection, I think that a lot of insurance companies focus particularly on the top 10% because it's much easier to predict who could be in that top 10% on the basis of these conditions, and whether or not somebody's older or female, whereas to predict who's in the top 1% is almost impossible. I would say it's virtually impossible. It's such a random occurrence of who ends up in that top 1%. So let me switch a little bit here and start talking about forms of competition that, to avoid high-risk people that insurance companies have been using. And I should say that in New York State, it's much harder for insurance companies to do this. So you guys may think, why are you talking about this? We don't have these problems. But I at least want to put out there that in the country as a whole, insurance companies do compete with each other in this way to avoid any adverse selection. So the first thing that they do, if they can, is to try and segment the market to be specialists in particular types of people or groups that they want to insure. So my favorite example of this is that if you were a poet or some type of writer or had your own small business, you would find it very difficult to buy health insurance on your own right now in most states. But if you join the chambers of commerce or a chamber of commerce in your hometown, it turns out that you can get a pretty low premium, relatively speaking, for an individual through the chambers of commerce across the country. There are at least half a dozen insurance companies that specialize in self-employed people who have the name chambers somewhere in the title of the company, in the name of the company. And what they go looking for are people who are self-employed, who think of themselves as small business people that meet on a regular basis, once a week or once a month, through their local chamber of commerce, and they sell insurance that way if the state will let them do that. So why do you think that they like people who are self-employed? Exactly.
Their income is tied to being.
Exactly. And they know that, so that if you were to say that you were sick, you would lose money, and they know that you're not likely to want to lose money. So you're a good person to go after in terms of trying to sell an insurance policy to you. I think they're aware that there are poets in some towns that are doing this, but the poets that I know about the chambers of commerce are people who have created weekend events where they get aspiring poets to come do an intense 3-day course in poetry or how to get your poetry placed in various journals and magazines. So the person is quite clearly an entrepreneur. So we can discuss that. But anyway, that's one example of specializing. There are other companies that specialize in people who have been in the armed forces or who are children of people who have been in the armed forces. And it's, again, the same kind of rationale that there's a macho characteristic of such people that they're not likely to use medical care as much. So they're good people to specialize in. I'm not going to belabor this point. The selection mechanisms that a lot of them use, as you know, relate to medical underwriting. In some states, they still can refuse to issue a policy to somebody who applies. They can, again, depending on which state you're talking about, exclude coverage for pre-existing conditions, and they play all kinds of semantic games as whether or not something is a pre-existing condition or not. But I think the fourth point that I've got here is the way that a lot of companies compete, and it's a way of being below the radar screen in terms of regulations. But as an economist, I can tell you that I think this is a very effective way to compete, and that is to design a slightly different benefits package in the policy that you're trying to sell, and to try and tease out or to try and separate people who think of themselves as being very healthy and they are not likely to have health insurance or health care costs in the next year, and people who think, oh, I might get sick in the next year, or given my family history, I might need this expensive care. And so this fourth point of differentiating what benefits are covered in the policies is the way that a lot of them are competing to try and stay away from individuals that they think could be higher cost, high risk of higher cost people in the future. And if they are in a state where they can do the medical underwriting so that they can have a higher premium for such a person, they will do that. But it's using this differences in the types of covered benefits that is a great way for trying to separate out people. In New York, you can't do that as easily. In Massachusetts, you can't do that as easily. And I would say we have better coverage of people who don't have health insurance from people who otherwise would have greater numbers of people without health insurance. So how do the states respond to these private insurance companies' efforts to stay away from people they think are going to be high cost? I would say that there are essentially risk management strategies that you could put into three different buckets. I'm sure we could put them into more buckets or to rearrange these types of buckets. But for purposes of this discussion, I've put them into strategies that would involve everybody who lives in a state, just some people who live in that state, and then the third is the people who could be considered at high risk of having very high costs. And Courtney nicely developed this inverted pyramid to further describe what I'm talking about. So I'm going to go through these in turn and first talk about strategies that involve pretty much everybody who lives in the state. You like that?
Yes, I was just
Okay. So first thing is that we could require everybody to have insurance. This would get at this voluntary nature of the way we allow people to purchase health insurance in the United States. And if we did require everybody to purchase health insurance, I think you'd have to do something exactly like Massachusetts has done, which is to make subsidies available to people who have enough income that they are not eligible for a Medicaid or Medicaid-like program where they would have it for free. And instead, you would give them a subsidy to help them buy a private policy. Because you are requiring people to buy health insurance, you are immediately blunting this risk of adverse selection in this market. Second thing you could do that a number of states have thought about, but only Massachusetts has done so far, is to merge the small group and individual insurance markets. And then third, you could create an insurance exchange, what I think of as a market-like entity, where people who either coming in through small employers or as individuals could go to this market, purchase insurance, and be treated as if they're part of a larger group of people. So it's a pooling mechanism as much as it's a market kind of mechanism. And Courtney asked me to talk about this in the context of what Massachusetts' experience has been, because we've done basically all three of these, and they're obviously of interest at the national level at the moment. I'm not sure they will continue to be, but at the moment. Okay, so the first thing I want to talk about is that we've had very little pushback so far on the requirement that everybody have health insurance coverage. But this is the year in which, in some ways, the rubber's going to hit the road. That is to say, the penalty for not having proof of insurance coverage will be much higher this year than it was last year. So maybe there will be more fussing about it. But it's quite remarkable that there is very little pushback on this. we have 187,000 people who are newly insured in private plans. And the surprise here is that most of that number come from people who are getting insurance now through their employer. That was not the expectation at all, that an employer would go back to a lot of these insurance companies and say, okay, what kind of policy can you offer me? Or they have extended insurance to people that previously they did not consider eligible employees. So these would be people who might work part-time, or as I talked about in my book, a lot of people who do what I call contract work, they're self-employed, and now some of these firms are saying, well, we're walking a pretty dicey line in terms of what the IRS says an employee is or not, so we're going to make it available to you. So that's the first surprise, that we have 187,000 people who don't qualify for a subsidy and they're getting health insurance through private plans. We have 174,000 people now enrolled in Commonwealth Care, which is the subsidized portion of what we have in this legislation. And as of May, so early this month at the early board meeting in May, more than 54,000 of this 174,000 are paying something towards the premium. But by flipping that around, another way of saying this is that around 120,000 people are getting full subsidies. So this is where the costs are coming in Massachusetts. And then we have 76,000 new enrollees in Mass Health, which is our Medicaid program, and of course they are fully subsidized as well. One thing I want to make clear here is that this increase in enrollment and designating people as being eligible for Mass Health or getting subsidies through Commonwealth Care could not have happened if Massachusetts had not built for its Medicaid program a very elaborate, sophisticated software platform which allows them to almost instantly be able to tell where a person's income falls in the continuum of do you get Medicaid or what kind of subsidy you get. And I think that is a frequently overlooked point about how well Massachusetts' experience rolling out this legislation, which was passed only 3 years ago, how well it's worked. And if a state does not have that kind of software available to it, and we happen to have it through the Medicaid program, I don't think this would work. It would fall on its face pretty rapidly, and it's not cheap to do this, although clearly these companies that have learned how to do this for Massachusetts can do it more cheaply for everybody else. The other point I want to make here is that the request for exemptions, because you can't request that you be exempt from this requirement that you buy health insurance, if you can show that even though your income is either just below the 300% of the poverty level where the cutoff for getting a subsidy is, but even with a small subsidy you can't afford to do this, or if your income is above 3 times the poverty level you still can't afford to do that, you can apply for an exemption. And people who are 55 to 64 particularly have been asking for exemptions because we do have, as I'll show you in a second, some modified community rating of the premiums, and it's people who are 55 and older who have to pay higher premiums. So if you're both 55 and older and close to the point at which the subsidies go away, you're much more likely to be in the group of people for whom this is really unaffordable, and that's by and large who's been getting the exemptions. But as I say, there's been really very little pushback on this. The second thing I want to say about all this is that the subsidies are much lower, much larger for lower income people, and conversely very low for people who are close to the 300% of the poverty level. What we've been seeing, and it echoes what I just showed you in terms of the enrollment, is that we have fewer people coming in that 200 to 300% of the poverty level because the subsidies fall off fairly steeply in terms of what a person would have to pay. So to give you an example of this, if you were an individual and not yet 55, if your income is below 150% of the poverty level, you pay nothing. So you would be in Medicaid if your income was below 100% of the poverty level. You're in Commonwealth Care if your income is between 100 and 150% of the poverty level, but you pay nothing. Between 150% and 200% of the poverty level, the premium is about $39 a month right now. But if your income is between 200 and 250% of the poverty level, your out-of-pocket premium payment is $77. So it's a big jump up once you cross that 200% of the poverty line. And if you go then from 250% of the poverty line up to 300% of the poverty line, your premium is, I think it's $117 a month, your out-of-pocket expenditure. So for somebody who's in that higher end of this income distribution that's still eligible for a subsidy, they're more likely to say, wait a minute, I'm either going to risk it, which is what we've seen this last year, there's been some, or you're going to ask for an exemption. This means that then the subsidy funds that were projected to be needed exceeded what had been projected, and it exceeded it for two reasons. One is that, partly for political reasons, the legislature decided what it thought it was doing was going on a middle-of-the-road decision about how many people in Massachusetts didn't have health insurance. And there were two, you may know all this, but there were two surveys done. One done by the state, and one done by the Current Population Survey, by the Bureau of the Census, which the Urban Institute analyzed for them. The Urban Institute estimates are higher than the state survey, not surprisingly, because the state survey was a much smaller sample size. And in addition, the census is, as you know, really expert at getting people to reveal different sources of income at a fairly accurate, so we can believe this, level of validity about their incomes. The state survey didn't ask as detailed questions, so what happened is that they had projections where they went sort of the middle of the road between these two estimates that were too low on how many people total were uninsured, but in particular where they got hit were the number of people whose incomes were below 200% of the poverty level who would need some subsidy money. So they were overly optimistic about how many uninsured people were in that lower part of this. So they didn't have as much money. They ended up being short on money for this. But it's as much a political decision as anything else. The other part of the reason that the state found itself short on money is that this growth in healthcare costs, which I was talking about before. Healthcare expenditures in the state have been much higher than they had hoped over the last couple of years. And I'm going to come back and talk about this in a second, but this is an issue which the state, I think, is now realizing it has to face. I do want to say that the Connector board has negotiated, and with some fanfare, an increase in the premiums for the people who are not getting subsidy that is lower than what it is if you work for a larger firm. So they're trying to argue that they've done pretty well that way. And part of it has to do with the merging of a small group of individual markets, they would say. But I think, again, there's been little fanfare about this, and I'm going to come back and talk about this in a second. But one reason for this is that the small firms are not actually coming to the Connector like people had expected. So let me turn to that. The other thing that is a big deal at the federal level now, and sort of zeroing in on what Massachusetts has done, has to do with this exchange in a place like a market where people could purchase health insurance. I thought this was one of the best things going about the legislation. It was a way of pooling people who previously could not be pooled, particularly individuals, people who work for small firms, and it would provide a choice of plans. So it answers the argument that a lot of owners of small firms, I'm sure everybody in this room has heard this, where the owner of a firm will say, I've asked my 8 people that work for me, what do you want? And they cannot agree on the kind of policy they want. And I can't force them to pay something that they don't want to, if they don't all agree about this, and I can't get an insurance company to sell me a policy unless all 8 buy it. So from the point of having this exchange, it's a great way of offering a choice to get around that problem. The Section 125 plans, as you know, allow the employees then to put their out-of-pocket premium payments into pre-tax accounts, which is, I think, in many ways only fair, given that people who work for very large companies get a tax benefit like that. It also allows for ease of payments in the sense that the Connector was going to collect these monies and bill individuals and then turn over the money to the various health plans that were involved in within the exchange. In some ways this sounds like Health Pass New York, but it differs in one critical requirement, which has to do with what I was just saying before, that we haven't had as many small employers coming in here. The difference is the requirement that I think I certainly missed until about 3 months ago is a requirement that premiums be the same for policies that are sold inside the connector that are the Commonwealth choice, that is the unsubsidized premiums or plans. And there are 6 different insurance companies selling the plans that way. The premiums have to be the same inside the connector as outside the connector. So if any of us in this room owned a small company and we went to, say, Blue Cross of Massachusetts and we said, okay, what can you do for us I'm a small firm, what premium can you offer me for the following benefit structure? It has to be the same as that same benefit structure inside the connector. And at the moment, the connector has not worked this out. It's something that they've got to do by the end of this year, because by the next fiscal year, so basically 14 months from now, 13 months from now, the connector is supposed to be cut loose from getting state funding, which helps support all the administrative activities. So what they're trying to do is say, we can add value because we're holding this exchange, we're allowing this market to work, we're orchestrating it. So we're offering value that way. We're offering value in terms of giving you good housekeeping seal of approval to the policies that can, or the plans that can be sold within the connector. But with this requirement that the premiums be the same, I'm sure all of you are now going, there's a conflict of interest here. And that has not fully worked itself out. They're struggling with this. So the problem at the moment is that while on the one hand, they were able to hold the premium increase to just 5% growth relative to more like 7 or 8% for large companies and double digits for small companies that across the country. The truth of the matter is that we've only had 19,000 purchasers coming in through this unsubsidized Commonwealth choice as of last September, and they haven't published the recent numbers on this. So this catch is really catching them at the moment. And I don't know how this is going to work out. But it's something that if we're thinking about doing at the federal level, or any other state is thinking about doing, I think you have to build in that there's going to be administrative costs in running this market-like exchange. And you may not want to get into this problem, which, if I were a cynical person, I would say the insurance companies cleverly caught the connector, or caught the legislators on it. But it still has to be worked out. Okay. Let me switch gears and talk about that middle part of the pyramid and talk about strategies that involve some people. And I'm going to go through this pretty quickly. Here, New York, Massachusetts have community rating of premiums. I think for a lot of policymakers, this was viewed as a way of reducing costs for premiums for people who are older, who are likely to face much higher premiums in an unregulated state, and to essentially ask people who are healthy or younger to help share in these costs. I think if we viewed this as a life cycle kind of contract where you're going to be in that particular insurance market all your life, you'd say, fine, I don't mind paying more as a younger person, so I don't have to pay more as an older person. I would say that and of course that doesn't happen, so there's a lot of resistance to paying more as a younger person unless we have a requirement that everybody do this, in which case then you can imagine premiums being lower. Community rating can exacerbate this adverse risk selection problem precisely because younger people are going to look at this and say, why should I join this? I'm not likely to have healthcare costs anywhere near that premium. And they don't think of insurance the way we would think of insurance. There also can be these group purchasing arrangements which affect some people. So again, Health Pass New York is a great example of that as a way of pooling risk. There are these associated health plans which have come around again. I feel like there's a 25-year cycle on this. I personally think they are a bad thing because they are unregulated. And so unless we, at the federal level, can change ERISA and open that up and start regulating associated health plans, I think that we could get right back into the scandals that we had in the late 1970s, which most people seem to have forgotten, which is that there were a number of these health plans, high and dry, no money, and people who thought they were insured by them who had health care expenses that were not going to be paid. In any event, these plans and some of the group purchasing arrangements don't directly address this adverse selection risk. What they do essentially is pooling the risk, but they're not going after the risk that you could have some people with very high costs. Which brings me to the strategies for targeting high-risk people, that is, people that you might expect to have very, very high costs. And there are three strategies that a lot of states have examined or used in various ways. I'm going to go through these in slightly more detail in a second, but there are high-risk pools, there are assessments on insurers, and then government-sponsored reinsurance. And I would say that this is a great state for talking about reinsurance. So let me talk about high-risk pools. These exist right now in 34 states, and the ugly truth is that they cover fewer than 200,000 people. So if you're looking at something that could take care of people that I said were very high risk, that is the people in the top 1% of the expenditure distribution, or the top 1%, top 1% of the population, we have over 300 million people in this country. So you can do the math. 200,000 is a lot lower than 1% of our population. They have high premiums in the states where they exist, and they require a fair amount of state funding because those premiums do not cover the full costs of the people who are been seeded to the high-risk pools. Which is the third point here, that the high-risk pools rely on people being seeded. That is, they have insurance or they apply for insurance, and the insurance company says, based on our models, we expect this person to have very high costs, we do not want them, and we are going to then give them over to this high-risk pool. That requires an extraordinarily accurate model that would predict ahead of time, ex ante, who should go into the high-risk pools, and we're very bad at those kinds of models. Assessments on insurers are one means of essentially sharing the aggregate costs of high-cost people among everybody who has health insurance or is covered by a policy that these insurers are selling. Prior to ERISA, and really prior to the early 1980s, when a lot of larger companies got the message that if they self-funded, that under ERISA they could avoid a lot of state mandates and state taxes. If you did this assessments on insurers through their insurance policies, you would have picked up just about everybody in the state who had health insurance, one way or the other. They would have been covered by a true health insurance policy. But starting in the early 1980s, human resource consultants got out there, and all these large companies realized right away that if they self-insured, that they were not going to have to pay attention to these mandates or pay these taxes. So one of the problems with doing an assessment on an insurer to help pay for these higher costs is that it misses all the people who work for large firms where the large companies self-insure. And it really does not reduce this risk of adverse selection faced by the very insurers who are still selling the small group and individual policies where they would be caught up in sharing these costs with very high-cost people. So all we're doing is essentially moving the chairs around on the deck of the Titanic. So this brings us to what you guys have in New York, which is a government-sponsored reinsurance program. It directly targets this risk of adverse selection because there is what's known as an excess of loss design. I'm sure all of you are very familiar with it in terms of how New York works. But it targets those people who have extremely high costs. Now, New York has changed the way the reinsurance works so that it's not going after the very, very highest cost, well above the $60,000 threshold, and instead has taken a slice of costs, as you know, between $5,000 and $75,000. But it is still capturing a lot of costs of people who have very high costs. And the key point here is that the determination of who's had those occurs after the fact. After the year is over, we know exactly who had high medical expenses. We don't have to predict it. And that aligns the incentives of insurance companies, particularly, to manage the care of high-cost people, which is exactly what we want if we're really going to be able to continue to expand health insurance. We need to manage the care so that we don't have such high costs of people at high risk. So these efforts to address the risk of high-cost people, the thing that it bumps up in terms of trying to expand coverage is it bumps into what we've been talking about with the rise in healthcare spending. All the strategies that I've just been talking about involve more money. We somehow need to get more money into the system. And that has created this real catch-22 that the growth in healthcare spending over the last decade, particularly, means that high cost or people at high risk of having high costs are now going to cost yet more to treat. So we've got ourselves into they cost more. That means we need more money for these subsidies. We need to set aside more money. How are we going to keep going like that? And it goes back to what I said in the very beginning, that I'm very concerned now that we are getting into, whether you want to call it seed corn, but it is. It's the money for all the kinds of infrastructure projects that President Obama has talked about. It's things like education. Kids, we need them to be productive in the future, so those of us, as we march off into our Medicare years, will still have health insurance. We have to think of something. We need to slow the rate of spending. So here the issue relates to what are we going to do in terms of states? Can states do this alone? And states have very different levels of spending, especially for high-cost people. Some states have more high-cost people than others. It's not clear why. We know that there are people who have strong preferences for living near academic medical centers. They seem to believe that they will therefore have better care, and they're the kinds that are most often likely to go into their doctor and complain. So then they do, in fact, get more medical care. But it's also the case that we know from studies that Jack Lundberg and others at Dartmouth have done, where we're still trying to parse out what does all this mean. But let me just show you, there is enormous variation in spending by what they've called these hospital referral regions, which are not coming out so well in this map. You can think of it by state if you want. The key thing here is, I'm sure you can't read it from where you are, but Manhattan, Eastern Long Island, where I grew up, and even Albany, New York, are in this list of pretty high-cost hospital referral regions. And since I suspect you can't quite read this, let me just tell you that New York City has, these were Medicare expenditures in 2006 per person. New York City, it's over $12,000. Suffolk County is around $11,000, and Albany is around $7,300. I'm going to come back to this in a second, but let me just go back to this point, that the fact that we have such variation, that there are some places that have very high cost spending, clearly affects this risk of having high cost people. If you were an insurance company, there are certain states you'd probably prefer to stay away from. And it also, for our point here, affects the state's ability to fund these strategies to manage risk, and the whole point of trying to expand health insurance coverage. They're in trouble if they're in a state that has higher expenditures. So the real question here is, can states control the spending by themselves? I think the experience in Massachusetts is pretty sobering. We have not yet been able to really slow down the rate of increasing healthcare spending. Now, part of this is that we haven't really gotten our cost control council up and running at the same level of funding and administrative funding that we did for the connector, and it's relying on other people to do a lot of its work. So in some ways it hasn't been able to do much, but I think that's part of the sobering experience. Another part of the sobering experience is that Medicaid accounts for 16% of total healthcare spending in this country. And that is a combination of state and federal dollars. So no state by itself, even with its Medicaid program, really has the leverage to affect these norms of how do we take care of people who come in with particular symptoms or diagnoses that we start throwing a lot of scans at, for example. And the third point here, that the growth in Medicaid spending, we now know from work that John Holohan and colleagues at the Urban Institute have been doing this last 6 or 7 years with much more detailed Medicaid data. We know now that this growth in spending is coming increasingly from increasing intensity of care that happens when somebody's hospitalized. So from the moment that they either come in through the emergency room or if it's some kind of elective surgery, but for most Medicaid people, it's coming in through the emergency room. So we really are in a situation where it seems to me there's no magic bullet. I don't know what it is. I'm hoping somebody in this room does, but I suspect that the bottom line is we are really going to have to be part of a conversation which goes after these norms of care for various conditions and symptoms. And I think I'm just going to go through some of these things, but I want to be clear here that I don't live in New York. I grew up here. I certainly go in and out of here for medical care related to my parents, so I can tell you stories. But I'm hoping that some of you have some ideas here, too, about what New York can do to address some of this. So let me just go through this pretty quickly. First, I think there is a need to address these norms of care. And I think that either state health commissioners working with state medical societies and hospital groups, governor, they have enormous bully pulpits. You know, I'm 5'4" and I'm being dwarfed by this bully pulpit, but it seems to me that you should take advantage of it and really start talking about the fact that we need to alter what we're doing. Some of this has to do with physician-owned equipment and the fact that once you own it, it's like that Field of Dreams movie. You know, if you build it, they'll come. If you own it, you'll use it. And even though Medicare has restrictions on this, it's still the case that hospitals own these scanning devices, and they realize that those are profit centers. So they're using them 16 hours, 20 hours a day. They're profit centers. And I think we really need to start thinking outside the box. So I've got a couple of slides of thinking outside the box. First is that we ought to be, and I think that we're now getting data that would allow us to do this, to really analyze episodes of high spending, to really uncover these sources of increased intensity of care. So one personal example is that my father had surgery 2 weeks ago, and they gave him a really powerful antibiotic. He has Parkinson's. My sister called up and said, I think there's an interaction problem here. They said, go to the ER. 12 hours later, and I'm sure at least $3,000 worth of costs, so a whole bunch of scans, because they just were not thinking, oh yeah, it could be the interaction. Look at the labeling on those drugs. I mean, what a waste of money. But it was a lot of intensity of effort that, you know, again, if somebody had been thinking, they wouldn't have done. And I think sort of, what are the symptoms? What's going on here? It's part of thinking outside the box. Second part of this is, why not think about extending hours of physicians' offices? Use that bully pulpit to make people feel guilty that they don't have enough partners in the medical group that, you know, a couple nights a week they're going to stay open later. This swine flu vaccine scare, you know, one of the things in Massachusetts that was a huge scare, and I'm sure it was exactly true in New York, was that people would flood the emergency rooms that first weekend. And I think that had the governor come out and said, look, go to your physician's office, something like that, we can take care of this without having unnecessary people in emergency departments where you're much more likely to have lots of intensive care provided. We could alter Medicaid incentives for nursing home patients to go to a hospital. Right at the moment, the incentive is that if you're in a nursing home and something isn't quite right, Medicaid incentives are get that person across the street to the hospital, then Medicare will pay for it. And of course, the person lives longer with lots of things done to them. And I'm sure all of you have horror stories along those lines. Another think outside the box set of ideas. Again, these are not novel, but we ought to be expanding the use of nurse practitioners and baccalaureate RNs. We closed down a bunch of nursing schools. We should reopen them. We should encourage greater use of them to visit people in their homes rather than having people go to a hospital for lots of things that could be done with monitoring at home. Geriatric training of physicians and RNs. And so here I'm picking up now on a lot of Medicaid expenditures are for geriatric patients. And the training for geriatric training is miserable in this country, and they will tell you that. And I think that we could reallocate Medicaid reimbursement rates, which of course is a huge political problem. I recognize that. But again, using this bully pulpit might help. So what can New York do? Clearly analyzing these episodes of high-cost care, I think you can do this with some of the data you have here. These reimbursements for people with chronic conditions could be higher. Worry about these dual eligibles. Work with Medicare to, through your Congress people and senators, to reduce the incentives to hospitalize. And the bottom line here is really pursue something what I call the old Rochester strategy, which is to think of yourselves as a community, what's good for this community, so it's part of resetting the norms. And I'll just tell you one story before I'm going to sum up. I know I've run late. Atul Gawande has an article in this coming week's New Yorker. And the map that I showed you of the United States, 2 places that he went to in this article. One is McAllen, Texas, which is the second highest hospital referral region in the United States, and the other is Grand Junction, Colorado, the lowest. And it turns out in Grand Junction, Colorado, they think of themselves as a town, and they view this as what's good for us, what should we be providing in care. And they didn't know until a year ago that they were the lowest referral region cost place in the country. So now their reaction is, oh, we should be going after more of that money. But, you know, the idea that they had there, they were not a profit center. It was working well. And I think that's something, again, for thinking about how do you reset these norms of care. So just to sum up what I've been talking about here, and I'm sorry that this went longer, but I think that it's important to remember that if you're going to expand access to insurance, that requires managing, of course, the risk of these high costs. And that's something that I certainly spent a lot of time just focusing on. But now I'm more interested in how do you control the medical costs and spending, particularly for these higher cost people, because if you don't, the whole thing is just going to implode. And I think that this current recession, like lots of people will talk about how this is an opportunity, and I don't mean to make light of the recession at all, and using the euphemistic word of an opportunity, but it is an opportunity to control spending and to really rethink how do we reset these norms of care. And I think the state of New York, being one of the biggest states, certainly with largest expenditures for Medicaid, has a strong voice in this, and that you could take advantage of that. So with that, I will quit.
Thank you, Kathy. That was a very excellent detailed presentation.